Hello, how are you doing? My name is Stephen Edwards and welcome to this week's video blog. This week we are taking on a very sensitive subject. It's about fraud and fraud awareness. We are going to talk about fraud awareness this week. Next week we're going to talk about what a clinic can do to protect themselves against what we are talking about today. So I'm just going to have a laundry list. There's no listing of importance or this is committed more than others. This is a general list. I'll explain it a little bit and then we'll wrap up today. I can tell you today's video blog is probably going to be a little bit longer than normal, but if you see on the YouTube the hyperlinks, you'll be able to go through the video blog quicker if you choose to skip anything. I would also like to encourage you to send me individuals' emails that you would think that this would be important. It doesn't have to be an EEP client. It can be a TheraPlan client. It can be a peer. It can be anybody. I'm trying to get this message out to as many people as possible, and so they can be aware of what's happening, potentially could be happening in their clinic. I've said fraud a couple times now. I don't want to say fraud throughout this video blog, so I'm going to start calling it issues. Just because fraud is this is a word I don't like using a lot. And going through and every other third word is that word, it can kind of make people freak out a little bit. So let's start the list. So the most obvious is billing a date of service without treating a patient. So you don't go visit little Johnny, but you bill for little Johnny. That's an issue. That could be a big issue for you because that could result in jail time if you're doing it on a level. And everybody's heard about the ABA clinics billing incorrectly and all this crazy stuff that happens in the healthcare world. Don't bill a date of service if you didn't treat that patient that day. Changing a date of service. Sometimes, because we're a specialty, we need authorizations for everything. If your authorization starts on 2/1 of 2019, you treat somebody on 1/30 of 2019, and you had no more visits. If you change that date of service to 2/2, so now you are inside of an authorization period just to get paid, we call it chasing a payment. That's an issue, and you should not be doing that. And you definitely don't want to condone that in your clinic just to get paid. If as administration or a clinic owner, you're telling, oh, just change that date, you're telling them to change a date of service. So you lose that moral high ground. So if they're doing something like billing a date of service without treating a patient, can you tell them not to do that if you're telling them to change dates? So please be very aware of that. The time therapy starts and ends. Most EMRs, including TheraPlan, will have a scheduled time when you first make that encounter. And then the therapist goes in when they document for that visit the actual time that they went in. So let's say somebody is scheduled from 1 to 1:30, but you actually treated them from 1:02 to 1:37. That is totally different than 1 to 1:30. So you want to make sure that you are putting actual time. If you're not, that could be construed as an issue. So please make sure you're putting in actual time and not scheduled time. Notes are duplicated for an extended amount of time. That is, well, a lazy provider. If you have a provider that does a great note or a bad note, it doesn't matter the data. I'm talking about they'll have 3 months of the same exact note. Even if a patient is super low functioning, you cannot have the same note repetitiously. If a home program, you give it to them, you have a home program for 2 weeks and then you change it, but it's the same 2 weeks in a row, that's not an issue. That's not what I'm talking about. I'm talking about a 3-month span where everything is exactly the same. That's an issue. A licensed provider not enrolled in a plan. So you have a provider you just hire, and they are not a provider under your contract for WellCare. But Betty Sue therapist is. So you take this therapist that's a licensed therapist, not an assistant, and you bill it under another provider. That's an issue. You can't do that. When you hire somebody, they should be treating out of network. Some of the commercial plans don't make you credential each individual therapist, self-pay. Those kind of plans, that is what you should be doing, and not Medicaid, WellCare, Molina, Prestige. They need to be credentialed as an individual therapist underneath your contract. Not adhering to the supervisor requirements for assistants. Let's say that you have an assistant that works in your clinic, and Betty Sue provider, licensed therapist, is the supervisor of that assistant. And Betty Sue therapist is not there that day, but the assistant is. That assistant cannot go through the whole day, treat patients without another licensed therapist in there. If you are doing that, or if somebody comes in on a Saturday and sees a couple patients as an assistant and there's nobody else there, that is an issue. You should not be doing that, and if you get caught doing that, the ramifications of that could be clinic closing if it's habitual. Not if you do one here, one there because the supervisor went out to lunch. I'm not talking about somebody going out to lunch and half of the visit is there's not a supervisor in the building. I'm talking about a known, she comes in Saturday and everybody knew that the supervisor was not going to be there on Saturday. That's an issue. Treating a patient 2 hours in one day and billing for 2 sessions over 2 days. So the parent's going on vacation, and this can be in cahoots with the patient or the parent. You treat them for 2 hours. You're there for PT for 2 hours, and you bill that one data service because you know that you're not going to get paid more than an hour. You bill 1 hour 1 week, and then that second hour that you treated them in the same day, you take and make a note for a whole nother day when they're actually on vacation. That's an issue. You cannot treat somebody double and then bill one data service 1 week, one data service another. Okay. Teaming with this actually happens, teaming with a patient or parent to bill more time. You have a lot of situations where one of your providers are friends with somebody, or maybe weren't friends until they started therapy, and they become in cahoots where you are billing and they are making notes for fictitious dates of service, and they're splitting the money. I mean, that is coercion. You do not want to get into that situation. Now, next week, like I said, we are going to talk about ways that you can combat this kind of stuff through your clinic, through EEP, or through Theraplan. But there's things that you can do to make sure kind of stuff is not happening. Having a goal on a plan of care that's never being worked on. If you are ever audited by ACA or by the MMAs, and you have 10 goals, and you really just worked 7, and 3 of the goals you just never did. It was either a bad evaluation, you came up with bad goals, or anything like that. In an audit situation, they're going to say you have not worked on these 3 goals. Why were they put on there? So you want to be very clear and concise on your evaluations and on your daily progress notes on what you worked on during that treatment. And make sure that you don't have goals that are just kind of falling through the wayside, because the doctor signed off on that plan of care and expects you to provide that and achieve those goals. So that is really all I have on the fraud issue standpoint. I'm going to just some additional thoughts that I have as we wrap this up. One, you and every provider that works for you and every administration that works for you, or if you are a provider watching this, assume your notes are going to be audited. Write them in a way that you know that a certain percentage of your notes are going to be audited. Please keep that in mind. Being a Medicaid provider, you have to have a self-audit program. And I can tell you, I've dealt with this. If you if you call ACA and you self-report something that has happened in your clinic that you discovered, I have never had ACA do a full-blown audit and put you under a microscope. Having said that, if a parent calls and complains to ACA that they never saw that patient on that time, and ACA comes to you, that is 100% different. That could potentially get very ugly. So you have self-reporting, and then you have patient or somebody in the community reporting you, maybe a provider that worked for you and now quit, and you were doing these weird things inside your clinic. You need to self-report. Anything that, if you call me and say, Steve, this just happened in my clinic, the first thing, and if you're watching this and we've had this discussion, the first thing I'm going to say, you need to report this to ACA, because if you self-report, it's a whole different ballgame than if ACA comes to you. You've probably heard me say this also if we've had meetings and stuff like that. Don't do anything in your clinic that you would not have a problem with getting in front of a panel of people and telling them what you did. I've had to do this for a client, and everything turned out fine, and it was all good because we had all our ducks in a row. But I literally was in front of about 10 people telling them what happened. So if intuition, if you're doing something and the hair on the back of your neck kind of sticks up and the voice inside you is telling you, oh, this doesn't seem right, most likely it's not. Call me, reach out to your account manager. Let's talk about it, because there's all different levels of issues, and some are black and white, and some are notes. If one form of a big issue is, I was reading a note this past week, and it was for oral motor, and it's funny because the note said ATE for oral motor. The note said ATE 8. Now, to me, that is like, well, one, the insurance should never pay that, and they should stop paying. But that's the kind of notes, as a clinic owner or as administration, you have to be reviewing and inspecting what you expect. So a half an hour visit of oral motor that says ATE, that's a quality, and you are not putting your best foot forward in relation to, documentation and making sure that you are out of the woods in any kind of audit situation. So I hope that this maybe sheds some light on your processes and an awareness throughout your clinic. Please have your administration watch this. Send me emails. Next week, again, is going to be how you can combat and make everybody aware. So I look forward to that. I hope you have a great day, and thank you for watching this week's video blog.